My name is Judson Brandeis. I'm a private practice urologist in Walnut Creek, California. Dr. Lynn, Dr. Cohen, thank you. Thanks everyone for coming. So I looked at the use of radial pulse therapy and a nitric oxide booster and its effects on the treatment of erectile dysfunction. I'm a GAINSWave medical advisory board member and a chief medical officer and founder of Affirm Science. The purpose of the study was to determine the efficacy of a combination of radial pulse therapy and a nutritional supplement consisting of L-citrulline and beetroot extract in the treatment of men with erectile dysfunction. We used 40 consecutive men, so that actually the first 40 men that I treated in my clinic. We used the Zimmer Impulse Pro shockwave therapy device. We treated once a week for 6 weeks at a rate of 15 and energy of 90 for a total of 10,000 shocks. We used the GAINSWave treatment protocol and 3 grams of L-citrulline and 360 milligrams of beetroot extract. What we found was that there was a significant improvement in SHIM score at 5 weeks. So pre-treatment, the patient's SHIM score was 11.8. 5 weeks after treatment, when we did the SHIM score on the last treatment, the SHIM score rose to 17. This gave us an average improvement of 5.2. Now, if you look at pre-treatment versus end-of-treatment SHIM score, our median SHIM score was about 5, consistent with the mean. 27% of our men were low responders with an increase of 2 or less. And 37.5% of our men were high responders with an increase of 7 or more. So in conclusion, the combination of weekly radial pulse therapy for 6 weeks and a nitric oxide booster taken every day resulted in an increase in SHIM score of 5.2. Now these are very preliminary studies. We've heard pretty much all weekend that more studies are needed to be done. And I intend in my clinic to do those studies, to try to follow large numbers of patients longitudinally over time. I also am looking into what's called triple therapy, or what I call triple therapy, which is shockwave therapy with a PDE5 inhibitor and a nitric oxide booster. I think that we need to figure out exactly what we can do to help these patients, both with shockwave therapy and with pharmacotherapy. But I think we all agree that there is a need for larger scale studies with shockwave therapy and with synergistic therapies like nitric oxide boosters, PRP, and stem cells. Thank you very much.
We'll open up for a few questions.
Mike Wiley from the UK. There's a very precise protocol you followed there, which I applaud you for. But could you just make me understand how you decided on the dose of L-citrulline and beetroot extract, and what evidence did you have that was actually nitric oxide booster?
Right, so there are papers in the literature, I think from Italy, on the use of L-citrulline and the dose of 3 grams of L-citrulline. And then beetroot extract also is a known nitric oxide booster. No additional testing on patients' nitric oxide levels pre or post was done, however.
Why did you decide to use both of the boosters rather than just see what contribution one made and then the other, and then in combination?
You know, that's a great question. We didn't quite have time to do one versus the other versus a combination. We just tried to take a shotgun effect and see if we could use as many things as there were scientific data for.
Okay, in fact, as you point out, it's preliminary. You weren't hoping to investigate it further, which once again I applaud you for.
Dr. Lichholz?
Yeah, excuse me, these questions asked more out of ignorance than, but you used a radial wave, right?
Right.
And is that, explain the difference between a radial wave and a focused wave, shockwave therapy, and what was the distance, what was the size of your port that actually hit the penis? Because I think it's larger, isn't it, than focused? shockwave?
So, my understanding of a focused shockwave, I'm not a physicist, is that you're basically focusing on a single focal point, like we do with extracorporeal shockwave lifters. And so the focused shockwave devices, like the STORS device, tend to be louder, tend to be more uncomfortable for the patient, and we're not trying to traumatize a particular small area of the penis. We're trying to spread the shock waves out from a central focal point. So the Zimmer device that we're using has a 15 millimeter head. And I've been talking to Tom Liu a lot about this, and what you really want to do is the sound waves perturb the cell membranes and perturb the membranes on the inside of the cell, and the mitochondria, the endoplasmic reticulum, and what they do is they send off inflammatory cytokines. Those inflammatory cytokines then generate an inflammatory response that generates VEGF and other vasculogenic factors that then result in increased vasculature.
So,
I answered your
so
question.
yours is a wide beam as opposed
It's
to...
a wide beam, correct. Because I don't think that you need to traumatize a small specific space.
We're probably gonna have a lot of questions on this. John, just one more.
Yeah, so my concern is that you're riding on the tails of the shock-wave therapy trials, the 16 trials that are being published in the literature, with no real equivalency assessment that that's what you're doing, okay? And so, you're just saying you're the same as shock waves, but you're not. And when are we going to get that kind of study and that kind of animal research to show that you are equivalent?
I think that's really a fantastic point. And I think, I've tried to work with Jesse Mills at UCLA, with Danny Shoskis. I've talked to a number of people about doing this. And it doesn't quite seem that the academic community has created very large-scale studies. But earlier in the week, folks have already remarked that the horse is already out of the barn. There are a lot of folks around the country that are doing this. And as Director of Clinical Excellence for GAINSWave, what I've talked to the GAINSWave folks about, and what they're very supportive of, is using the GAINSWave network of physicians to try to do very large-scale studies. Now, we're not going to do studies that are similar to academic studies. Folks in the community aren't going to do sham studies. We're probably not going to do penile duplex ultrasounds. We're probably not going to do arteriograms or angiograms. But what we can do, as pointed out earlier, is provide you with large amounts of data, thousands and thousands of patients that healthcare researchers can actually sit through and figure out. Because it's really important to understand who does well and who doesn't do well.